I'm going to try to emphasize the benefits of identifying and managing the disease as early as possible. And when compared to Peter's presentation, mine is going to be very basic, very simple. I just want to deliver a message for the countries without any nationwide screening program, as in my country. So the DR Barometer study, conducted in 2 arms, has revealed really good and interesting results. When we look at the most fearful complications of diabetes in our patients, they all say that it's vision loss. But on the contrary, we know that around 1 out of 6 of those patients only discuss symptoms once they have already arisen, and about 1 out of 8 patients never discussed these eye complications with their physicians. And patients are aware of the severeness of the visual loss, but they are not managing their diabetes very well and not doing everything that they can do to prevent visual loss. And we know today that less than 1 in 3 of the patients were screened in time. And about more than 2/3 of the patients come for screening only when the visual problems have already occurred. So, what are the reasons for that? It's the lack of understanding of the diabetes-related eye disease complications, long waiting times, high cost, and poor referral pathways, lack of multidisciplinary approach, and several others. As I've said yesterday, we need referrals and we need early referrals. That's the main message, I think. We all know that diabetes not only impacts the patient's life, but also the caregivers and the families. And early diagnosis and the initiation of treatment with anti-VEGF agents is crucial. When we look at the study from BRCR network group, we know that patients who have a lower visual acuity at baseline were more likely to improve and more likely to achieve visual acuity gains, but they are less likely to reach a near normal visual acuity when compared to the patients with a good baseline visual acuity. This, I think, summarizes why we need early referrals. And the same thing can be derived from the VIVID or VISTA studies. Patients who were on the control arm, in the laser arm, were allowed to have Eylea treatment, aflibercept treatment, after week 100, but they achieved smaller gains, but they have never caught up with the groups who were initially treated with anti-VEGF agent. So again, early treatment is important. Delaying the treatment is not beneficial. Screening, of course, has the potential to reduce the prevalence of diabetic retinopathy-related blindness. And I think you have seen this slide before, yesterday. When we look at the leading cause of blindness in the United Kingdom between years 1999 and 2000 in the working age group, diabetic retinopathy has been the leading cause, but after the introduction of anti-VEGF treatment in United Kingdom and Wales, no longer diabetic retinopathy is the leading cause for blindness in the working age group, but it is the hereditary retinal disorders. So it's changing. It has changed a lot. For people who are not familiar with screening programs, I think I should say that there are several steps for the screening. First of all, eligible patients are invited for screening, and usually digital retinal photographs are obtained, and those images are then graded. They are usually graded into 2 groups, either as low-risk eyes or higher-risk eyes. Lower risk eyes consist of eyes without any retinopathy or eyes with very mild non-proliferative diabetic retinopathy. Those patients actually were invited for annual rescreening. But in the group of higher risk eyes, where you detect preproliferative or proliferative diabetic retinopathy, or diabetic maculopathy, or where the images were ungradable, then those eyes were referred to a retina specialist. All those images actually may undergo multiple analysis by image graders before the referral. But of course, it's a challenging program. First of all, manual grading is labor. You need manpower, and it requires very well-trained human graders. And also, it's costly, and cost effectiveness has been explained very well by Dr. Scanlon. Here, we have to consider about that. When we look at the numbers of diabetics in the world and its projection to 2040, it's scary again. And we have to do something about it. So a solution for that is automated retinal image analysis systems. Those systems allow the detection of diabetic retinopathy without requiring a human grader. And those systems has been reported to be comparable to that of a human grader with high degree of sensitivity. But of course, those systems should be validated, should be able to be performed in real life and in high volume settings, and those systems must be safe and again cost effective. The accuracy, diagnostic accuracy of those systems was tested in United Kingdom in more than 20,000 patients and on more than 100,000 images. And that was reported by Adnan Tufay from Moorfields. And actually, 3 systems were tested as eye grading M, red marker, and IR for the specificity and the cost effectiveness. What was their results? Red marker and IR achieved acceptable sensitivity and false positive rates for referable retinopathy. So, and the specificities of red marker and IR also were sufficient to be cost saving. For a program about 20,000 patients, use of those systems was predicted to save between 80 to 100,000 pounds. Another good example is Portugal, and the use of those systems was introduced in Portugal in 2011. And we have Rufino Silva here in the audience, and I'm sure he can comment on that better than I do. And since its implementation, those systems, automated retinal imaging analysis systems, has reduced the burden of grading by 48% when compared to manual grading. But of course, again, those systems should be validated, and maybe we can start to use artificial intelligence and deep learning for that purpose. So in conclusion, we know that delaying the treatment in patients with diabetic retinopathy may cause irreversible visual loss, and that's why we need regular screening and timely intervention. Since the introduction of nationwide screening in UK, diabetic retinopathy is no longer leading cause of blindness. Implementing a screening system in a country can be challenging, and the image grading process is also very costly and intensive. But we have also some other electronic or some other retinal image analysis systems for that purpose. And by doing so, we may reduce the cost and manpower required for screening, and we may improve the access for the patients and facilitate earlier diagnosis and intervention. Thank you for your attention.